executive plastic surgery. So a very interesting case, relatively similar to the yesterday's one, more or less the same. So this is a nice 51-year-old female. She got implants in 2015, her first set, saline through the armpit. And then she got what is capsular contracture, and then in 2019 she ended up getting another set below the muscle. At that time she also got what is a full lollipop anchor lift. Then capsular contracture occurred again, and then in 2022 her third set of implants, and she ended up getting another set below the muscle and also a lift at that time as well, as mentioned by the patient. So now, as you will see right here, 2015 above the muscle, 2019 below the muscle, 2022 below the muscle. And so the task was to remove the entire implant capsule below the muscle, which is right here. Also, there was significant contouring done. You can see this hypertrophic scarring that she had, and a lot of asymmetry between the right and left. She had grade 3 capsular contracture on the right, grade 4 on the left. And as you will see, a lot of scarring tissue. And look at this extension right here. It's like a triangle, like a sharp 90-degree bend. And so going back to over here, you will see the protrusion that's done en bloc. I want you to go ahead and appreciate this was below the muscle. Remember, below the muscle is the hardest part of the case. You can see the cartilage part of the rib, and this is where the entirety of the implant capsule was removed. And you can see how it's pointy, and I have to be able to dissect. This tissue is very hard and abnormal. I had to remove it. This is part of the scar tissue, and I'm going to actually cut right through it. So done en bloc. Now these implants are just 3 years old. Extremely unlikely that they're ruptured, but there was a lot of scarring, and you can see right here, I'm going to go right through it, and a lot of scarred tissue. And you can see like all of these scar-like extensions, like hard mass, if you will. So anything hard, irregular, abnormal is removed. And so as I go in, you get to appreciate what is a grade 3 contracture. This is minus the pain. And see how it's folded up on itself. So some people feel these irregularities, these pointy aspects of the implant because of the contracture. And because she did not have pain, it's a grade 3. Had she had pain, that would be a grade 4. So as I remove, you can see how it's bunched up, intact implant. And look at the way it was sitting, right? So you're feeling this. Sometimes someone may feel and say, what is this mass? And actually it's the implant. So done en bloc, the gold standard, complete en bloc, 10, 16, 25, initials SM. And you can see, look, this is how it was sitting. Like, this is how the implant was sitting. And so if I press this open, you will see it does not want to even, like, branch up. It wants to kind of go to that, the way it was contracted. So this is your 320 Allergan implant, and there's some fluid around. So if I go like this, look at this leaching of that silicone that's occurring, and look how deformed it is. All this inflamed tissue, abnormal tissue, has been removed. Look at the pocket right here. You can see my glove, the green glove, how thin some areas are. Also of note, I saw as I was dissecting some suture. All of that removed, everything removed. So you can see, I'm going to go ahead and make a cut right here into the capsular tissue. You can see it en bloc done completely. Tricky case. So I'm going to cut right here. You can see these, a small ridge step off. So there's your ethibond suture right there. So all of this, there's a suture granuloma type of reaction going on, because remember, the body is recognizing this as foreign right here. So all of the foreign material has been removed, and it's a very thoughtful, contained dissection. Now this is the above the muscle, what is scar tissue, inflamed tissue, and what is suggestive of capsule as well. And we'll see what the pathologist says. This is going to be sent separately. So I'm going to go ahead and put my instruments on the other side. I'm going to remove my top glove. I have another sterile glove underneath. Remember, I'm going to take cultures on the inside so that I get a good biofilm sample. So you will see right here, scar tissue for contouring purposes. The distance from the nipple all the way down to the crease on both is 5.5 exactly. So that's my balancing that I did. I cut more skin on the right than on the left to balance the two. And again, I just want to highlight, look at this, how pointy. All that end block. And if you look at the back, you will see again the carvings of that cartilage right here, consistent with what is an end block. And again, just like on the very thick and hard tissue, abnormal. I have to remove this. I don't want to leave this behind. What if this is potentially ruptured, right? And so as I cut, look at that scar tissue. If I touch it, it's hard and irregular. Actually, I'm going to enter from here, and you will see like how suffocated and compressed this implant is. So very hard mass. You can see as I cut this open, and I'm going to cut it such that we will see how the implant was sitting. So see how pointed this is, and if someone's doing an exam, they might feel a mass. Certainly you have to think rupture. If you look at the Mentor advertisement, see this is how the implant was sitting, and again on the inside you will see a lot of tissue. You can see that vein in the back. Some areas so thin, you can see my glove right here, look. But everything, there's no fluid, so this is why end block is key. We don't want any of that to spill into the periphery, and I'm very happy and content. Let me go ahead and cut this area just out of curiosity to see what this is. Very hard, very thick. And you see, there's a small pocket that I am seeing here. But we'll see what the pathologist is going to say. I'm going to rest this here. Let's go ahead and open this up. If I go like this, see now it spreads out, but it wants to go back. Literally, it's been like this for the last 3 years. So this is your 320 Allergan as well. 320, and again, look at this. All contain none of this, and I want to touch this one. This is above the muscle. Scar tissue, inflamed tissue, capsule. What is residual capsule? That's what it is. So the implants will be returned to the patient. Capsules to be sent to pathology. Rule out the BIA, LCL, CD30 analysis. Rule out lymphoma. Rule out malignancy. Rule out any abnormal pathology. Cultures for aerobic, anaerobic, and fungal. Residual capsules above inflamed tissue, scar tissue to be sent, and we'll see what the pathologist says. So complete clean out above the muscle, below the muscle, on the sides as well, especially when the implant is introduced to the axilla area. So there is what appears to be remnants of the capsule because the implant moved up and down, very likely given the path that was created when the implant was put in. So there we have it, the complete thorough workup. She'll have the peace of mind, all the bad tissue is removed, only good healthy tissue remains behind, and certainly a big part of this case was the breast chest contouring given the grade 3, grade 4 capsular contracture that she had. This is Dr. Khan, executive plastic surgery. Sten was